Good morning. I am Amr Kamal, talking to you today in the Egyptian Society of Cardiology, the review course, and we will speak about the sudden cardiac death. The importance of sudden cardiac death is that it is a devastating consequence of a myriad of cardiovascular conditions, and it's all too commonly the first manifestation of a previously occult pathology. Due to the unpredicted nature of the sudden cardiac death and the associated difficulties in identification and retrospective determination of etiology, accurate quantification of disease burden has been difficult. We will start by the definition of sudden cardiac death. And sudden cardiac death, by definition, is the unexpected death of an individual not attributable to an extracardiac cause, usually within 1 hour of symptom onset, or within 24 hours of last being seen in good health if the death is unwitnessed. The epidemiology of sudden cardiac death is very variable. We have to know that it's estimated that there are up to 5 million cases of sudden cardiac death per year globally, with an annual incidence of 50 to 100 per 100,000 population. Sudden cardiac death is a major health problem and a major public issue, accounting for 50% of years of potential life lost from heart diseases. Although the majority of sudden cardiac death occurs in adults and incidence increases with age, there is a bimodal distribution of the incidence, with an initial peak between 0 and 5 years of age before a much larger second peak occurs between age of 75 and 85 years of age. The main problem with sudden cardiac death is that the majority of out-of-hospital sudden cardiac arrests occur among patients in whom cardiac arrest is the first clinical expression of the underlying disease. This is the main problem of sudden cardiac death, or in those in whom disease has previously been identified but classified as low risk. So the problem that it occurs without an identifiable high risk, or as a first clinical expression of underlying occult disease. We can see here in these slides the incidence and occurrence of sudden cardiac death over 1 year in general population, in high-risk subgroups, in any prior coronary events, in people with ejection fraction less than 30%, in cardiac arrest survivors and arrhythmias, risk markers, post-myocardial infarction, and we can here see a difference between the incidence in general population, which is highest in events according to the trials, and in patients with low ejection fraction, the same in patients with high-risk subgroups, higher occurrence of events. But the strikingly concern here is that the high rate of events among people in general population, even those with low risk. So there is an inverse relationship between the incidence and absolute number of events, as we can see in the previous chart, and indicating that a large portion of the total population burden emerges from subgroups with lower risk index. This is the main problem in sudden cardiac death, that people with sudden cardiac death usually have a lower risk index, thus making the identification and prevention of future events particularly difficult. The incidence of sports-related sudden death from any cause in the general population is relatively low, about 0.5 to 2 per 100,000 per year. And although the vast majority of such cases occur during middle age, they represent relatively small population, 5% of the overall sudden cardiac arrest cases. And this is, of course, is a lucky thing. For the etiology of sudden cardiac death, coronary artery disease is the most common underlying cause of sudden cardiac death. It accounts for at least 3/4 of the cases is due to ischemic heart disease. And the sudden cardiac death accounts for 50% of all coronary artery disease related deaths. The cardiomyopathies and genetic channelopathies account for the rest of the causes of sudden cardiac death, being at least 20% of cases. Here in this graph, we can see simply the etiology is 75% due to coronary artery disease, 15% is cardiomyopathies, whether dilated or hypertrophic cardiomyopathy, and in cases of arrhythmogenic right ventricular dysplasia, and 2% for inherited arrhythmia syndromes, either long QT, Brugada, catecholaminergic polymorphic ventricular tachycardia, and early repolarization syndrome. About 5% for valvular heart disease like aortic stenosis, and others like coronary anomalies for 3%. Here is this table demonstrates the etiology in details. For ischemic heart disease, myocardial infarction, including non-ST elevation myocardial infarction, is a major cause of sudden cardiac death. Anomalous coronary origin and coronary spasm also contribute to the ischemic etiology of sudden cardiac death. For inherited channelopathies, as I just mentioned, long QT, short QT, Brugada, early repolarization, and the catecholaminergic polymorphic ventricular tachycardia are the inherited arrhythmogenic syndromes that leads to sudden cardiac death. Cardiomyopathies like alcoholic, hypertrophic, idiopathic, obesity-related, fibrotic, arrhythmogenic right ventricular cardiomyopathy, and myocarditis all are among causes of cardiomyopathies that lead to the sudden cardiac death. Heart failure, especially with reduced ejection fraction less than 35%, are high-risk group for developing sudden cardiac death. Aortic stenosis and tetralogy of Fallot are among the lesser group of causes of sudden cardiac death. Other causes like severe electrolyte disturbances, massive pulmonary embolization, vigorous activity in sedentary life, and acute psychosocial and economic stress can lead, of course, to the potential of sudden cardiac death. Here we will discuss in details the disease that can cause sudden cardiac death. First of all, the ischemic heart disease, as I mentioned, as a group, is one of the major groups of can cause sudden cardiac death, about 75%, as I mentioned, for the cases of sudden cardiac death, either an atherosclerotic or non-atherosclerotic coronary artery disease on coronary angiography, on CT coronary angiography, or in autopsy with signs of ischemia. And the risk stratification here, those patients with reduced ejection fraction. And how to prevent, the strategies to prevent sudden cardiac death in this group is revascularization, either stenting or bypass surgery for atherosclerotic coronary artery disease, and coronary bypass or reimplantation for the coronary anomalies. For the second most common cause of sudden cardiac death, which is the hypertrophic cardiomyopathy, we have to identify the features clinically and pathological for the hypertrophic cardiomyopathy as left ventricular wall thickness more than or equal to 15 millimeter, myofibrillar disarray and interstitial fibrosis on biopsy, and the gene mutations of the troponin and myosin broadband mutations. The risk stratification here is those patients with resuscitated cardiac arrest with wall thickness more than 30 millimeter, or with patients with family history of sudden cardiac death associated with hypertrophic cardiomyopathy, patients with unexplained syncope, non-sustained VT, or abnormal blood pressure response during exercise testing. And those patients, of course, should prevent strategies a strategy for the prevention of sudden cardiac death is the ICD in selected patients and exercise restriction. Again, in ischemic heart disease plus revascularization, also guideline-directed medical therapy of beta blockers and ICD in selected patients with ventricular tachycardia in the EP lab, or patients with symptoms of heart failure or NIHA score more than 2 is also indicated for ICD therapy. Among other groups of cardiomyopathy is dilated cardiomyopathy, which is an entity that can cause sudden cardiac death, and the features of dilated cardiomyopathy is increased cardiac mass with dilated ventricles and no inflammatory or infiltrative features, or coronary artery disease. This gives the dilated cardiomyopathy a clinical features. And also some gene mutations that leads to dilated cardiomyopathy, like laminin gene associations. For risk stratifications in patients with dilated cardiomyopathy, patients with resuscitated cardiac arrest, or patients with severe reduction of ejection fraction and NIHA score 2 or more, and lamine AC mutations with non-sustained VT and ejection fraction less than 45%, with a non-missense mutation, male sex, all are high-risk group that may need an ICD in selected patients, plus, of course, the guideline-directed medical therapy in terms of beta blocker and ACE inhibitors that could improve mortality in such patients. For the arrhythmogenic right ventricular dysplasia, we have diagnostic features like the epsilon wave or T wave inversion in the right precordial leads, V1, V2, or V3, and fibrofatty replacement of the ventricular myocardium with some gene association in some type of patients. The risk features here, those patients with poorly tolerated ventricular tachycardia or patients with resuscitated cardiac arrest and significant ventricular dysfunction of the right ventricle or left ventricular ejection fraction, 35% on the cardiac MRI assessment. And those patients, of course, are eligible for beta blocker treatment as a strategy to prevent sudden cardiac death, and exercise restriction, of course, in some cases, plus ICD or implantable cardioverter defibrillator in selected cases. Another condition, which is cardiac sarcoidosis with increased myocardial thickness and non-caseating granuloma. Those patients with high risk include patients with resuscitated cardiac risk, syncope, reduced ejection fraction, myocardial scarring, and imaging reveal myocardial scar with inducible VT in the EP study. And those patients are eligible for ICD and immunosuppressive therapy for active disease. For mitral valve prolapse, we have also some risk patients, high-risk patients with mitral valve prolapse, like people with ventricular ectopy, female sex, bileaflet prolapse, degree of mitral regurgitation, the severest, the highest is the risk, and myocardial scar on cardiac MRI imaging. And those patients, for strategies to prevent sudden cardiac death, we have to avoid the stimulants avoidance, and beta blockers can improve that, of course. For long QT syndromes, which are inherited arrhythmogenic syndromes, we have many types, like QT 1, 2, and 3. The ECG shows QT interval prolongation, which is exceeding the normal values, which is 440 milliseconds in men and 460 milliseconds in women. There is also, of course, a genetic association of the sodium channels here and potassium channels that can lead to these long QT syndrome types. Those patients with corrected QT more than 500 milliseconds with syncope on medical therapy, the women with long QT syndrome 2 and resuscitated cardiac arrest are all high risk group, and we have to prevent sudden cardiac death in such a group by avoidance of QT prolonging medications, which is available on the FDA.org website, a long list of drugs that could precipitate long QT. Of course, beta blockers like propranolol or nadolol, sodium channel blockers in long QT syndrome 3, and left cardiac sympathetic denervation and ICD in selected cases. The other channelopathies is Brugada syndrome, which is more than 2 millimeter coved ST segment elevation in one or more of the right precordial leads, spontaneous or induced with drugs or sodium channel blockers like ajmaline, and genetically determined in sodium channel mutations. The high risk is resuscitated cardiac arrest, and of course the base of prevention of sudden cardiac death in Brugada syndrome is fever management to avoid fever, and to appropriately treat high temperatures in such patients. Also, we have to avoid a long list of drugs that can lead to Brugada, like drugs that is sodium channel blockers like Ajmaline and similar drugs, catheter ablation in refractory cases, and ICD in selected cases. For the catecholaminergic polymorphic ventricular tachycardia is stress exercise. The ECG leads to bidirectional or polymorphic VT with some gene dissociation, and high-risk patients involving patients with syncope or resuscitated cardiac arrest, and they of course are treated with beta blockers, flecainide as a second line, exercise reduction, left cardiac sympathetic denervation, or ICD for selected cases. These are the inherited arrhythmogenic syndromes. As I mentioned, this table can give a summary about the detailed inherited arrhythmogenic syndromes, the long QT syndromes, Brugada, catecholaminergic polymorphic ventricular tachycardia, and early reprioritization, and how is the diagnostic criteria on ECG, as I mentioned, provocation test indications, and how the diagnostic provocation test findings lead to the diagnosis. The pathophysiology of sudden cardiac death is very important, and VT or VF was thought to be the most common cause of out of the hospital cardiac arrest, accounting for approximately 75 of cases, remaining 25 being bradyarrhythmias or asystole. But the most recent studies suggest that incidence of VF or pulseless VT as the first recorded rhythm in out-of-hospital cardiac arrest has declined to less than 30%, and pulseless electrical activity, electromechanic dissociation, and asystole are more frequent than VT-VF at the first recorded rhythm in out-of-hospital cardiac arrest cases. Recent data demonstrate that a pulseless electrical activity is about 19 to 23%, 50% of patients having asystole, and the majority of survivors are in the subgroups whose initial rhythm is VF or pulseless VT, or between brackets is shockable rhythm. VF is a cause of cardiac arrest, and if untreated, the arrhythmia is usually fatal. The overall survival after out-of-hospital cardiac arrest remains low at approximately 7%, only 7%, and up to 75% of patients with out-of-hospital cardiac arrest have VF recurrence during pre-hospital care, and the time in VF is of course associated with a worse outcome. So what investigations to be done in sudden cardiac death survivors? A full cardiac assessment is needed in all patients. Patients presenting with VF or sustained monomorphic VT are at a considerable risk of recurrence, especially those with low ejection fraction. And the following tests are useful in establishing the diagnosis in sudden cardiac death survivors. First, ECG, signs of ischemia, myocardial infarction, inherited channelopathies, echocardiography for reduced ejection fraction, presence of cardiomyopathies, valve disease, aortic stenosis, congenital heart disease like tetralogy. And coronary angiography is special for the diagnosis of coronary heart disease, congenital coronary anomalies, or coronary spasm as a cause of sudden cardiac death. Exercise test is of special importance is ischemic causes, long QT provocation, or catecholaminergic polymorphic ventricular tachycardia provocation. Also, EP testing is important, especially for induction of arrhythmias, pharmacological provocation for Brugada, long QT, catecholaminergic polymorphic ventricular tachycardia, and prokinamide testing or Ajmaline testing may provoke Brugada pattern irrespective of the baseline, which could be hidden in some cases. Cardiac MRI is of special importance in the diagnosis of occult cases of arrhythmogenic right ventricular dysplasia, sarcoidosis, myocarditis, myocardial injury from coronary spasm. Lastly, is genetic testing and cardiac biopsy. Genetic testing is indicated when an inherited phenotype is detected, but its role in phenotypically ambiguous or negative patient is not established, since it is not always possible to differentiate between disease-causing mutations and irrelevant genetic variants. Cardiac biopsy may be needed at the last resort in patients with elusive cases. So what to do if the patients where the cardiac arrest is apparently unexplained? There is a protocol which is was done in the Barts University in UK, which is called the Barts the Barts protocol, where cases of ischemic heart disease are excluded, ejection fraction is preserved, and repolarization disorders are not apparent on the resting ECG. Further assessment is required, and this may increase the diagnostic yield and provide diagnosis in the nearly half of patients where an initial diagnosis is unclear. This is the protocol starting 12-lead ECG, lying and standing, which is important to reveal a lot of channelopathies and some cases of myocarditis of cardiomyopathy. Then, if not, we can do a high right precordial lead ECG that can lead to the diagnosis of type 1 Brugada syndrome change. Imaging like echocardiography, cardiac MRI, and cardiac CT or CT PET can lead to the diagnosis of a structural heart disease, cardiomyopathy, or myocarditis. Then provocation of either exercise testing or Ajmaline test for the long QT Brugada syndrome or catecholaminergic polymorphic ventricular tachycardia. And finally, EP study, genetic testing, and cardiac biopsy, as I mentioned. What to do for surviving relatives? The determination of the cause of death in sudden cardiac death cases is a vital step in caring for surviving relatives. This is very important, the relatives of the patient. If a genetic cause is identified, can provide critical guidance in family screening and in help prevent further sudden cardiac death events in the relatives. Family members of young sudden cardiac death victims are at increased risk of ventricular arrhythmias and ischemic heart disease, and the screening of first-degree relatives is very important when findings suggest cardiomyopathy or genetic channelopathies, especially if they are young, less than 35%, and the evaluation of other family members is also necessary. This is algorithm of assessment of sudden cardiac death, starting with a pre-morbid history of the decedent, including a review of any pre-morbid cardiac investigations, ECG, echo, cardiac imaging, then autopsy for including macroscopic, histological, and toxicological assessment that can reveal a non-cardiac cause of death identified, or there is no structural cause identified, or a structural cardiac cause identified. If a structural cardiac cause identified, genetic condition or non-genetic condition. If non-genetic condition, so standard cardiac risk factor management. If a genetic condition or a non-structural cause identified, so we have to go for clinical plus or minus genetic screening, initially first-degree relative. This is the flow chart of how to assess sudden cardiac death algorithm in the decedent and his relatives. The detailed pre-morbid history is very important, is a key in identifying the diagnosis, and especially useful in those cases with no structural cause identified. A past medical history should be thought, particularly in inquiring about exertional symptoms, syncope, drug use, prescribed or illicit, intercurrent illnesses, any cardiac investigations such as ECG, cardiac imaging, which must be reviewed in this situation. A comprehensive family history, as I told you, and detailed pedigree, gathering information on family history of cardiac disease, syncope, sudden death, including the sudden infant death syndrome cases, and suspicious traumatic deaths like drowning or unexplained motor vehicle accidents, which may have resulted from sudden cardiac death, may establish a hereditary pattern. Some witnesses can provide important information about the circumstances of death, like blunt trauma, sudden blunt trauma in the chest in cases of commotio cordis, and diagnosis of sudden cardiac death due to cardiac channelopathies may occur at any time, especially with classical triggers like swimming in long QT type 1 and loud noises in long QT syndrome type 2. How to manage cardiac arrest? A population-based cohort study on out-of-hospital cardiac arrest survivors detect an improved 30-day survival from 9.4% in 2002 to 13.6% in 2011. And survival is much better in places with facilities of bystander resuscitation, defibrillators in public locations, in train stations, in airports, in hospitals, and in schools may reduce the incidence of sudden cardiac death when the local population is trained to use them. The majority of cardiac arrests occurred out of the hospital with poor outcomes, and the survival to admission may be low as 8% and survival to discharge low as 3% for out-of-hospital cardiac arrest. And the first step to improve outcomes involving the chain of survival. This chain is very important. First is immediate recognition of the cardiac arrest and activation of the ERS, the emergency response system. Second is early CPR with emphasis on chest compressions. Third is rapid defibrillation. Fourth is effective advanced life support. And fifth is integrated post-cardiac arrest care. The management of sudden cardiac death is a disease-specific therapy with risk stratification and defibrillation. The goal of the management is to prevent adverse events and identifying at-risk individuals and instituting therapy to protect against sudden cardiac death. Uncovering a diagnosis in a family through clinical screening can also help to shed light on the cause of death in the deceased where this has not been previously identified. And disease-specific treatments variably targeting and improving quality of life, reducing risk of cardiac arrest, and reducing mortality, but the mainstay of sudden cardiac death is the implantable cardiac defibrillator. Secondary prevention, ICD, is recommended in these patients if no reversible pathology is found and there is no contraindication and they are at high risk of sudden cardiac death. The primary prevention of sudden cardiac death is targeting those who are at increased risk of sudden cardiac death but who have not had event before is a far more complex domain, and for patients with a diagnosis, disease-specific therapy is used to manage any symptoms. In some cases can reduce mortality. Risk stratification process is a disease-dependent and include history, ECG features, ejection fraction, cardiac MRI imaging, and EP study. And following sudden cardiac death as a consequence of a hereditary pathology, family screening of first-degree relatives is performed to identify individuals at risk of sudden cardiac death from an inherited cardiac disease who would benefit from intervention to prevent sudden cardiac death. Consideration of ICD therapy as a primary prevention should be balancing the benefits versus harms and should be discussed with the patient in a shared decision model of care. And careful consideration must be given to who will benefit from a device, taking into account the risk of sudden cardiac death compared with the risk of device-related complications on the long term. Accurate risk stratification is critical to ensure adequate primary prevention of sudden cardiac death without exposing people at low risk unnecessarily to hazards of ICD therapy, and this is particularly important in young patients or young individuals for primary prevention who will have significant cumulative device-related risk over their lifetime. Finally, I would like to thank you for giving me time to elaborate on a major health problem like sudden cardiac death, and wish that you enjoy the lecture. Thank you very much and goodbye.